Well, hello there. It's Alicia, and I am going to be talking about a couple of research articles that I recently read for our mutual benefit. So it'll be good for me to talk over some of these issues that I've picked up on from reading these papers, and also I think it'll benefit you to hear a little bit about papers that you might not have access to if you don't have university privileges like I do. And I'm planning to present this video in two ways. One will be as a video for those of you who like something to look at while you're listening. And for those who are more interested in just the audio, I'm also going to be providing this as a podcast. So win-win, hopefully. So if you don't already know, my name is Alicia Reve, and I am a doctoral student at the University of Florida under the mentorship of Dr. Karen Hegland in the Rehabilitation Science doctoral program. So I generally study swallowing, and in addition to that, I also look at other airway protective behaviors, which is a recent addition to my portfolio now that I work with Dr. Hegland. And for a while, I've been interested in the actual relationship between swallowing and dysphagia and aspiration pneumonia. So the two papers that I have right now are actually specifically about oral care, oral hygiene, and aspiration pneumonia. So I'm going to talk about them in reverse chronological order. So I'm going to start with the 2019 study first. And I'm probably going to butcher the pronunciation of the authors' names, but I'm going to give you enough information that if you wanted to look up these papers, you could. And if you would like to email me because you want to talk about these papers in greater depth, or you would like to get a hard copy of it and you don't have access to do that yourself, I could share my copy of the paper and we could talk about that as long as I'm allowed to do that, which I think I am. So anyway, let's start. So as I mentioned, the general topic for these two papers that I'm going to be overviewing are the relationship between oral care and aspiration pneumonia, or potentially more broadly just pneumonia in general. And I'm going to follow up this with a further discussion specifically about types of pneumonia, drawing from the experience of people who do more pulmonary research. But as of now, we'll skip that. And if you do have more questions about what makes a pneumonia aspiration pneumonia versus another kind, we will get there, because I think that's a really big deal for those of us who do speech therapy, swallowing therapy, etc. Okay, so the first paper that we're going to talk about is from a journal that is Supportive Care in Cancer. This is an original article that was published online. Online. Were you published online? It was published online in January of 2020, but the paper was accepted in December of 2019. So as today is the somethingth of January, let's see, today's the 17th of January. So this is pretty new in the world of literature. And the paper title is Prevention of Postoperative Pneumonia by Perioperative Oral Care in Patients with Esophageal Cancer Undergoing Surgery. It's a multi-center retrospective study of 775 patients. So I'm going to break just the title down a little bit. Some of the authors here are Sakiko Soutome is the first author. And again, I really apologize for not having a better awareness of Japanese phonology. Please forgive me. Second author is Takumi Hasegawa. Third is Taihei Yamaguchi. Not Yamaguchi, but Yamaguchi. And then last author is Masahiro Umeda. So 10 authors on this paper, and it looks like these authors are associated with the Joint Research Committee of Japanese Society of Oral Care. Japanese Society of Oral Care's Joint Research Committee. Something like that. So breaking down the title of this paper, it's Prevention So this is interesting. It's a retrospective study, meaning that they didn't specifically implement a treatment to see effect versus a group that didn't get the treatment. This is retrospective. So that's going to be one of the weaknesses of the study design, in terms of if you're looking at that traditional randomized control study as the top of the pyramid, and a petri dish study is the lowest in terms of clinical evidence. Anyway, so prevention of postoperative pneumonia. Notice that it's not specifically saying aspiration pneumonia here, but just pneumonia, by perioperative oral care. I actually had to Google what perioperative meant, and it's actually the time before your surgery, all the way through surgery and recovery before you get discharged from the hospital, is my understanding. So perioperative oral care in patients who are undergoing surgery for esophageal cancer. So this is a multi-center study, which means that patients aren't just coming from one hospital, but multiple locations, which is actually pretty interesting. It looks like there are 25 hospitals that are participating in the study, which is really cool, because I like that they're able to talk not just about one hospital system, but broader trends. And what's also cool for me about this study is that this is a bigger data set, which is something I'm sort of moving toward in my own interest in study. So starting with our abstract here, the risk factors for postoperative pneumonia that they've got listed here are poor general health, not surprising, smoking history, decreased pulmonary function, diabetes mellitus, surgical stress, old age, postoperative aspiration, and if you were counting, that's the 7th on this list, and the 8th item that they're listing here as a risk factor for postoperative pneumonia is oral hygiene, which again is sort of the point of this particular study. So we've got 775 patients. They all had thoracoscopic esophageal resection between 2016 and 2017 across 25 hospitals. So what we're looking at is they got a bunch of different factors for the patient's health over the time that they preoperative factors and postoperative factors, and then they looked at whether having professional oral care done to these patients around the time of their surgery, whether that would actually contribute to a lower rate of lung infection after the surgery. So I thought that was really cool. Now, starting out, as I mentioned, this is a study done by a group out of Japan. And in Japan, it seems to me from this study, you actually have dentists and dental hygienists on staff in the hospitals, which I was asking a couple of colleagues about this the other day before a class of mine started, and they were saying, no, not really. You might have like an oral maxillofacial surgeon on staff at the hospital here in the United States, but not dental hygienists, and more of the oral care here would probably be provided by nursing or potentially an occupational therapist called in to assist with the patient doing their oral care, because that's more of like an occupational or activity of daily life sort of thing. So what they actually did in this study was they had professional oral care done to these patients before they went in for their surgery, which I thought was interesting, because I kind of thought, well, maybe they'll do oral care after the surgery, but they actually did it before the patients went under anesthesia and had their esophageal surgery. So they wanted to see whether this professional oral care would reduce rates of pneumonia after surgery. And not only did they do this professional cleaning, which is it's explained here in this oral care intervention section under the methods, which says every patient in the oral care group received professional oral care by a dentist and dental hygienist before surgery. And it included things like oral health instructions, so instructions to the patient that they could continue oral care after surgery. They had removal of dental calculus, which in parentheses it says scaling. I'm not a dental expert, but maybe that means something to you. Professional mechanical tooth cleaning, removal of tongue coating, denture cleaning, instructions for gargling, and extraction of teeth with severe periodontal disease or severe periapical pathology, which to me says just like their teeth were janky and they just had those removed, as opposed to leaving them there as potentially a place where dental caries or cavities could be a breeding ground for bacteria. So interesting to me. And then so it says that was all before surgery. After surgery, patients received oral cleaning at bedside. And in those who could gargle, they got instructions on frequent gargling with water, which is also interesting to me because I might have suspected they would say gargle with a mouthwash or something with sort of like an antibacterial component, but it was just gargling with water to help keep the oral cavity clean. So what they also looked at, they looked at some different like indicators of health, which I guess we'll talk about in a second. But if you were curious how they defined pneumonia here, because as I said, we didn't specifically look at, this paper is not specifically talking about aspiration pneumonia. Again, unclear really what they would have meant by that anyway. But in this case, they diagnosed pneumonia with the presence of fever, elevated white blood cell and C-reactive protein levels, and pulmonary infiltrates, which required antibiotic therapy by a surgeon, according to some previously reported criteria, which I have not dug into yet. So if you're specifically curious about what those criteria are, they have some citations that you could follow. They got information about the patient's age, sex, history of smoking, history of drinking, diabetes, whether they've had any corticosteroids or other immunosuppressants. They also did forced expiratory volume percentage in 1 second, or FEV 1%. They got levels of hemoglobin, serum albumin, which I personally don't know much about these specific indicators, albumin, creatinine, cancer staging, of course, because they were esophageal cancer patients, operation time, blood loss, the method of the reconstructive surgery, neoadjuvant chemotherapy, postoperative dysphagia, and whether they had the oral care intervention. So for this postoperative dysphagia component, I wrote a question to myself to just ask, well, what kind? Because it doesn't seem surprising to me that after you would have esophageal surgery, you might have an esophageal dysphagia. But the focus in here is on oral care intervention, so I'm not sure. I'm not really sure what kinds of dysphagia they were talking about. So they did say postoperative dysphagia was defined as choking when a paced diet was started after surgery, aspiration during swallowing by video fluoroscopic examination, or continued tube feeding at the time of discharge. So those of us who have a pretty critical mind might already be thinking, I'm not really sure about the way you've defined dysphagia here, because I'm not really sure how much aspiration was allowed, how many times they aspirated, what consistencies they might have aspirated. Would it have been okay if they didn't aspirate, but they were still sent home on a modified diet? Would that have still counted as dysphagia? What if they had dysphagia that was something like odynophagia, but not choking? So it's a little bit unclear to me what they actually meant. And that's, in my understanding, kind of the only place where they really explained what they meant by postoperative dysphagia. So that, to me, was a little bit interesting. If you want to pay attention to the statistical analyses that they used, they were doing an ANOVA and Fisher's test. If you're curious to understand more about statistics, I'm just learning statistics now, so I'm probably not the best person to teach you about it. But in conclusion, in their results, they said that postoperative pneumonia occurred in about 12.8% of the patients that they had enrolled in this study, which again was a total of 775 patients. The predictors for this that were significant with a p-value lower than 0.05, I'm sure many of you are familiar with that. What would you call that? That's just like a standard. It's, what is the word for that? It's kind of a default that we use statistically to suggest whether something is mathematically more likely to be related to the variables we're talking about as opposed to just there by random chance. It's I just had the word for it in my brain and then I lost it. Language people, help me here. So what they found to be a significant predictor of those who did get the pneumonia, again, that being 99 out of the 775 patients, it was that if you were older, you had lower hemoglobin. I don't personally know what that means. Higher creatinine. Don't personally know what that means. A free jejunum graft. That relates to the reconstruction. And postoperative dysphagia. Those were all significantly correlated with development of postoperative pneumonia. Now, I'm going to just say it. I'm sure you personally listening to this know, but correlation is not causation. So we're not sure that these are the reasons, what came first, chicken or the egg, but you can see it's not only the postoperative dysphagia. That's not the only thing that predicts whether someone would get pneumonia after their surgery. So they did a multivariate analysis and found 6 independent risk factors for developing pneumonia. So So 6 independent risk factors. They were old age, which made you 1.041 times more likely. Smoking habit makes you 1.64 times more likely to have gotten the pneumonia. Lower hemoglobin, 0.875. Odds ratio is 0.875. How do I interpret that? Okay. Maybe it makes you less. I should look into this before trying to interpret it for you. The odds ratio for lower hemoglobin, by the way, then is 0.875. Higher creatinine has a higher than 1 odds ratio. Postoperative dysphagia, odds ratio of 1.971. And a lack of oral care intervention. So if you did have the oral care intervention, you were less likely. If you didn't have the oral care intervention, you were 6.601. What is that? 60% more likely to have postoperative pneumonia. So the other interesting thing that they did here was they separated their hospitals. As I mentioned, they looked at 25 different hospitals for this study. And they separated those hospitals into hospitals where there was a higher incidence of postoperative pneumonia, meaning that 20% or more patients who went through the surgery got postoperative pneumonia. And then they had lower incidence hospitals where fewer than 20% of patients who had surgery would get postoperative pneumonia. So you can see that maybe it's the types of people that go to these hospitals. Maybe there's a hospital in a more rural area where patient overall quality of health is lower, so they have higher incidence of pneumonia. Or maybe you have some factors intrinsic to the hospital where maybe the standard of treatment or protocols that they implement are different, leading to a higher overall rate of patient postoperative pneumonia. So they separated those out by not just patient characteristics, but patients who went to this hospital all patients there tend to have a higher rate of post-operative pneumonia. And then other hospitals, I think only 6 of them, where there was a high rate of post-operative pneumonia, meaning higher than 20%. So they did this analysis further, and they found that in the hospitals where more patients tended to get post-operative pneumonia, the oral care intervention didn't make a difference. The oral care intervention only made a difference for your risk of getting post-operative pneumonia. It mattered when, oh my gosh, that was Tammy getting down off the couch. This oral care intervention only helped patients, on average overall, if you were in a hospital that already had a low incidence rate of post-operative pneumonia. But if you were in the hospital where 20% or more of patients generally get pneumonia, the oral care intervention didn't help. So it seems like the oral care intervention by itself isn't going to necessarily help patients who have esophageal cancer. They're going to have a surgery for it. And if you do this oral care, it doesn't seem like it's enough by itself. That's sort of my interpretation of what they're saying here. So I'll separate out the other factors too. So they had 19 of the 25 hospitals where the incidence rate of postoperative pneumonia is lower than 20%. So the risk factors there were old age, postoperative dysphagia, and lack of oral care intervention. So if you were younger, you didn't have dysphagia, and you got the oral care intervention, your rates of pneumonia would be improved, right? You're not as likely to have it. But for the patients in the 6 hospitals where overall they have a higher rate of postoperative pneumonia, the risk factors for getting the pneumonia were higher creatinine, the free jejunum graft, which again is related to the type of reconstruction done, and postoperative dysphagia. But oral care didn't matter. So you can see that the postoperative dysphagia is a significant predictor for whether you're going to get pneumonia in this particular study, regardless of whether you're in a hospital that overall has a higher incidence rate of pneumonia or a lower incidence rate of pneumonia. So I thought that was really interesting. In the discussion section, they're talking about some of the papers that make up what's already known about this topic. And it sounds like in Japan, the incidence rate of postoperative pneumonia after a major esophagectomy is reported to be between 7 and 50%. And there are a bunch of different risk factors for that we have talked about, including smoking, decreased pulmonary function, having diabetes, being older, having surgical stress. So something was more stressful on your body going through the surgery than not. How much blood loss you have during the surgery, how long the surgery takes, and complications and so on. So yeah, so this study to me is interesting because so here in their conclusion, one of the main causes of postoperative pneumonia is aspiration of oropharyngeal fluid containing pathogenic microorganisms. Thus, postoperative dysphagia and oral hygiene condition are thought to be important factors for postoperative pneumonia. Again, we're going to talk about this a little bit more in this next study, and then I have a couple others that I've read. But it seems like dysphagia is still being shown to be a risk factor, but I'm not sure if it's enough all by itself, and oral care might not be enough all by itself. But it could be the case for sure. This is not necessarily coming from this paper, but it could definitely be the case that you don't have dysphagia, but you do have poor oral care. And there's another paper I've read to support this. I'll grab that later on. But you could have poor oral care in the absence of dysphagia and still get aspiration pneumonia, especially if you're breathing in those pathogenic microorganisms during your sleep when you aren't necessarily expected to be swallowing foods and liquids, but it would just be oropharyngeal secretions, not necessarily related to swallowing. So let's see, is there anything else I want to talk about here? As we talked about, the way that they defined postoperative dysphagia... Cammie, no. No, puppy. Oh my gosh. All right, taking a break. So Cam's expressing some feelings over there. Okay, yeah, so postoperative dysphagia here was defined interestingly. It was defined as choking when a paced diet was started after surgery. I'm not really sure what a paced diet means. I don't know if that's thin liquids, but, you know, paste consistency for the foods, or if this also includes the liquid consistency. I'm not sure. Aspiration during a fluoro swallow study, or continued tube feeding at the time of discharge. And we know that the reason for tube feeding could be multifaceted, and I'm not sure how that necessarily relates back to swallowing pathophysiology. So I'm not positive about that. I don't know, when you say that postoperative dysphagia is an independent predictor of of pneumonia after surgery, it's hard to tell how much weight to give that, given that the definition of postoperative pneumonia or postoperative dysphagia is, it's both broad and specific, and it's not, I don't know what I don't know what this means. And again, having tube feeding, if it's the result of esophageal pain versus a physiologic inability to move food, I don't know. I just don't know. And I would really like to see that be more clear, and have the rationale be more clear to me why the dysphagia would be an indicator depending on what kind of dysphagia it is. Does that make sense to you? If you have a different feeling about that, absolutely let me know. I would love to sort of like talk about it, because I read papers and a lot of times I read them in a vacuum, and I would like to hear what other people have to say about it. In grad school, we definitely talk to our friends and other students and professors and so on about papers, but when you're just reading for your own clarification or you're exploring a topic, it's not like I can make someone else read every single paper that I read so that I have someone to talk to about it. So now you're here, and you can be that person for me. Okay, so the other paper that we're going to talk about right now is from the Journal of Dental Sciences, and this is a study out of Taiwan. So this one was available online in 2017. So as I said, this one's older. And this one is a study. The last one was specifically a study that looked at patients with esophageal cancer who underwent an esophageal surgery for their cancer. Now, these patients are not esophageal cancer patients. So in the first place, when I'm presenting these in the same conversation, but they have different patient populations, they're from a different country. So this is not apples to apples. This is maybe apples to oranges, or apples to, charcuterie. It's different. So don't try to just compare them exactly. So this one, I'm even worse at Taiwanese phonology. So this one is risk factors of aspiration pneumonia. Again, another difference. The last one was any kind of pneumonia following surgery. Risk factors of aspiration pneumonia related to improper oral hygiene behavior in community dysphagia persons with nasogastric tube feeding. Already a very different topic. We have three authors here. We have Huang, Chi-Chen Chao, and Su Yue Lu. Oh, I'm sorry. Please teach me how to pronounce your names if you're the people who wrote this paper. Published in the Journal of Dental Sciences, 2017. And it looks like the folks who did this research are at the Kaohsiung Medical University in Kaohsiung, Taiwan. So this paper is looking at individuals who are living in the community, so not in hospitals like the patients in our last study, and they're patients who have dysphagia and an NG tube. So what they were looking for here was, okay, let's look at patients who are living in the community, I think there are two kinds of places that they're living. Some of them might have been in like nursing homes, and the other ones might have been living at home, but with caregivers. We'll get to that, and I'll double check on it. But this is a cross-sectional study where they looked at 128 patients who had dysphagia and an NG tube and who were living in the community. And they looked at their corresponding caregivers to see, especially because I believe they were only looking at patients who, yes, all of the patients in this study were bedbound, and all of the patients had caregivers who were providing them with assistance for ADLs, including oral hygiene. So they were looking not just at patient behaviors, but the behaviors of the caregivers and what kind of oral care they were providing to see whether that was a risk factor for these patients with dysphagia, with NG tubes, and whether they got aspiration pneumonia or not. So we've got here, they did a self-reported questionnaire, and they were focusing on the kind of oral care given as well as the timing of the oral care, which was interesting because I don't think that was necessarily a factor that we talked about in this 2019 study where we were just looking at perioperative oral care, but we didn't focus on like time of day that the oral care was provided. So it's interesting. So in this particular cohort of 128 patients, 55 of them, which is 43% of the total study population, the patient population for the study, right, because the caregivers are included here as well, developed aspiration pneumonia. Now, the way that they defined aspiration pneumonia should be of interest to everyone here. And it starts in their introduction with a definition of what is aspiration pneumonia. Again, last paper we looked at was just postoperative pneumonia. They didn't specifically talk about how the pneumonia was acquired or anything else. But here in our in this study, our 2017 paper, aspiration pneumonia is defined as a misdirection of oropharyngeal or gastric contents caused by dysphagia, accompanied with massive oral bacteria flora and secretions to invade into the larynx and lower respiratory tract, and then to produce an infectious response in the lungs. We're going to break this down just a little bit, which is absolutely not to just, crap on these authors, but is to just discuss for clarity what they're talking about here. So, oropharyngeal contents could include food, drink, or secretions. Gastric contents, I suspect, is talking about reflux. Now, if you have reflux, that does not necessarily, in my brain, does not necessarily mean you have dysphagia. Having gastroesophageal reflux disease is a different diagnosis here in the United States than having dysphagia. So here it's kind of interesting because it's a misdirection caused by dysphagia, a misdirection of oropharyngeal or gastric contents caused by dysphagia, which suggests that after there's reflux, the person should swallow, and then if the swallow is disordered, the material will go into the larynx and trachea as a result of the swallowing disorder, not as a result of the reflux. So maybe that's kind of what they're getting at, but I don't know. I just personally don't know if you have reflux. Is there in otherwise healthy, normal people a one-to-one relationship between a reflux event and immediate swallowing? And could it be the case that, like, is there a standard for how long it takes between the reflux event and the swallowing event? Is there a normal range there? Is there a range outside of which you could fall, which would mean that your swallow response to reflux is abnormal? I'm not sure. And I especially don't know anything about this in sleeping, which I know reflux can be, I know, but I think reflux can be worsened by being in like a supine position. So I'm not sure. The other components of their definition here of aspiration pneumonia, it says that the oropharyngeal or gastric contents would be combined with massive oral bacteria flora and secretions to invade into the larynx and lower respiratory tract. So what I like about this is it's separating out the idea that you just aspirated some water, just straight up water, or you aspirated some reflux just by itself, with the idea that it's separating that from the idea that you could just aspirate water and get pneumonia. That's not what they're talking about. They're talking about you're aspirating, but what you aspirated was mixed with oral bacteria flora, which I don't think would have to be oral, especially if it's like gastric contents that never go to the level of your oral cavity. It could be pharyngeal flora, right? So I'm not positive about that, but I do appreciate that they're saying it would have to be aspiration of something due to dysphagia plus, and I don't know, I also don't know, they say the word massive oral bacterial flora and secretion, but it seems like perhaps that could just be critical levels. I don't know if it has to be massive. I just know what they're trying to get at seems to be there's enough bacteria that it could be infectious, as opposed to just, when you normally inhale small amounts of your secretions that have some bacteria in them, but it's not a pathogenic amount. It's not an amount that's going to actually cause you an infection. And then the last component here is it introduces an infectious response in the lungs. So again, this is nice because they are differentiating between other kinds of respiratory responses. It seems like they're differentiating between pneumonia and pneumonitis. So that might be cool, but I'm not 100% behind this definition. I think there's some benefits to the way they described it, and I also think there are probably some major problems with it. I'm not sure. But at least they did try to define it for you in the first sentence of the entire paper, as opposed to leaving you wondering, well, what are you talking about? So that's what they're talking about. There are a couple of other issues I have just with their introduction, because they use the word always, and perhaps in Taiwan, there's such an overwhelming percentage of patients with these conditions that saying always probably is okay, but maybe not. So the first sentence they have is dysphagia persons, or, we can interpret that with person first language as people with dysphagia, always have problems in loss of sensation and mobility, paralysis or weakness of affected sides of the mouth and limbs, which makes them unable to feel whether food is pocketed in the mouth or not. They can't take care of their activities of daily life, their ADLs, including toothbrushing by themselves, or cannot get proper oral care from caregivers. I'm not sure here whether they're talking about people with dysphagia in Taiwan generally or the study population. It's in the introduction section, so this would suggest to me they're talking about the broader population. And of course, we know that people can have dysphagia for a lot of reasons aside from, unilateral weakness, paresis, paralysis. You could have midline structures that are affected that aren't necessarily divided by laterality. So here, there's sort of an assumption that you're going to have numbness in one side of the mouth and maybe throat, and so you're going to have problems with pocketing, but we know that not all dysphagia presents the same way, so when they say always, I take issue with that, but let's keep going. The next paragraph starts, this is still in the introduction section, dysphagia elderly, so elderly people with dysphagia, always suffer from chronic malnutrition and dehydration caused by the difficulty of taking meals and drinking orally. They do have a citation. They have 2 citations for this. So I'm not sure whether this is a problem of what they're citing or the way that they're interpreting what they're citing. But again, at least in the United States, I don't believe we think that all elderly individuals with dysphagia suffer from malnutrition or dehydration. So take this with a grain of question mark. And then they specifically talk about stroke patients. So I'm not sure if overall they're trying to talk about unilateral stroke patients, but they say stroke patients have poor oral health status in tooth loss, dental caries experience, and periodontal status, and less dental attendance. There's no citation there. There is on the next sentence, which says, this is caused by the lack of oral health knowledge by nurses and poor patient attitude. To which I responded, LOL, what? So there's a little bit of background here that's kind of interesting. They end their entire introduction section by saying, since long-term care elderly always have poor oral hygiene and unmet needs in oral care, we investigated to find out what is incorrect about the caregiver's skills in daily oral care and how poor oral hygiene status has been involved in developing aspiration pneumonia for patients with dysphagia with NG tube feedings. So, interesting. Actually, it looks like this is copywritten by the Association for Dental Sciences of the People's Republic of China. Okay. I'm curious whether then they're pulling patient data on patients specific to Taiwan, greater area of China, or if they're citing other international papers. So I'm just going to skip to their citations. There are 30 references here, and I'm going to just go through the journals. I don't know how informative this will be, but I'm going to go through the journals that they've cited. So we've got, the first one is from Current Opinion in Pulmonary Medicine. Then we have the Journal of Nutritional Science and Vitaminology. Interesting. Pan Minerva Medical Journal. Clinical Geriatric Medicine. Age and Aging. Journal of Public Health Dentistry. Journal of American Geriatric Society. Dysphagia. We've got a Pace and McCulloch paper from 2010 that they've cited. Journal of Oral Rehabilitation. It's their 9th citation. We've got Geriatric Nursing, JAMA. Current Opinion in Clinical Nutritional Metabolic Care. Got Israeli Medical Association Journal. Journal of Clinical Nursing, Postgraduate Medical Journal, Gerodontology, Gastroenterol Respract. Is that respiratory? I'm not sure. Okay, here's the Journal Dysphagia again. We've got the Journal Stroke, Journal of Stroke and Cerebrovascular Disease. Another one from the Journal of Age and Aging. Gerontological, a biological science, I'm not sure. I'm just not sure. So possibly because this is by a group of dental researchers, they're citing some journals that I'm not as familiar with. So International Journal of Stroke. That one looks to me like a Japanese journal. It's Kokubyo Gakizashi, which is the name of that journal. One on trials and then one from lung. So I'm not really sure. And I don't know that this paper isn't necessarily written for SLPs. So that also could explain some differences here. What did they find? Let's talk about what they found. What did y'all find? So, okay, let me tell you about who the patients are, and then I'm going to tell you what they found. So subjects were those who had had an NG tube for more than 6 weeks and were in home care for more than 3 years. They were, it says, have clear consciousness. Basically, it was a physician's decision about whether they were cognitively intact at the time of discharge, have communicable skills, and a full past medical history record. So that was, those are who were included. And then the evaluation of oral hygiene and health status was conducted at bedside by a dentist. The dentist looked at halitosis, which is bad breath that the dentist can smell at bedside, deposition or oropharyngeal secretion, which was plaque deposition on more than 25% of teeth, or the fixed prosthesis or removable denture, or oropharyngeal secretion more than 25% attached to the soft tissue of the hard palate and cheek mucosa, dry mouth, gum bleeding spontaneously, whether the patient was closing their mouth and not allowing the caregiver to brush their teeth, their status of dentition, whether they were edentulous or had teeth, and then brushing ability by the caregiver, so whether they needed partial or complete oral care by their caregiver, and gum bleeding that happened during brushing. So they looked at all of these different components, and as I mentioned, they surveyed the caregivers, and they found that the caregivers said overwhelmingly that oral care is really important, really critical, which is great to just have that recognition. It says also that 92% of the caregivers were providing the oral care. So, as I mentioned earlier, the timing seemed to have mattered in this care. So, in this study. So, what they said was important was that patients who had aspiration pneumonia were significantly different in that they had oral care after getting up, meaning like waking up in the morning, or they would have their oral care done using a sponge stick instead of using a toothbrush. So if they got their oral care when they woke up in the morning, they were 14 times riskier for aspiration pneumonia as opposed to getting their oral care before bed. And those who got their oral care with a sponge instead of a toothbrush were 3.29 times more likely to have what was called in this study aspiration pneumonia than those who used a toothbrush. So that was really interesting to me. So I know a lot of times when I was working clinically in the hospital, I was doing oral care on patients using those toothettes. I would they were a little bit softer, and we didn't have toothbrushes. When I worked in skilled nursing facilities, we had toothbrushes, toothpaste, and mouthwash that I could give to every single patient that I saw. I always checked their bathroom. I always checked with them whether they had dentures, teeth, if they were edentulous without dentures, and I always made sure to get them toothbrushes, those dissolving tablets for, that you soak your dentures in overnight, toothbrush, toothpaste, mouthwash, the denture tablets, and a denture bath station, basically like, a little cup. But when I was in the hospital, we didn't have toothbrushes around that I recall, and I could be completely wrong because I did that back in like 2015. But yeah, I was using tooth sets with mouthwash and sometimes tooth sets with just water, depending on what I was trying to do with somebody's oral care. Like if I was just trying to pull out big chunks of like dried secretions, a lot of times in those cases, I wasn't necessarily using like mouthwash, but I would take a wet tooth set or even one of those like cotton tip swabs, and I would just try to get all that stuff out. Um, but anyway, okay, so that was really interesting to me that those two factors were independent predictors. Now, they also said that having bad breath, having oropharyngeal secretions, having dry mouth, and closing your mouth and not allowing your caregiver to brush your teeth they also had a higher prevalence of aspiration pneumonia than those who didn't have pneumonia. So that was interesting to me as well. So it seemed like there are multiple factors that contribute to your risk of pneumonia if you're in this patient group of you have an NG tube, you're bedbound, and you rely on caregivers to help you with your oral care. So yeah, for those caregivers who are providing oral care, it was better if you provided it before the patient went to bed. And it was better if you provided it with a toothbrush than if you just used an oral swab. So I think clinicians can think about this, even if you're not just working with patients with NG tubes, even if you're not in Taiwan. I think that is interesting. And again, there are some things about this paper that I don't love, but yeah, I thought that was really interesting. And I think the reason that I think this is so interesting is because the rationale to me makes sense. The people who wrote this paper are dentists. They're in oral hygiene, special care dentistry in a medical hospital. And again, it seems that dentistry associated with hospitals might be more common abroad than it is here in the United States. That's sort of my understanding right now. But they were saying that they stated here, I think in the discussion section, that the sponges that are used for oral care aren't effective at removing plaque from teeth and in between teeth, like at the gums. So for me, that makes sense why the sponge wouldn't be as effective. I think the idea of the gums bleeding either spontaneously or in reaction to brushing, maybe that's a general health indicator, or maybe it's an indicator of the absence of oral health care. So what I'm thinking there is, like, if your gums bleed, it's either due to a condition that maybe doesn't have as much to do with your oral care routine, or maybe it has to do with a sensitivity because you don't do your oral care very often. So I'm not positive 100% what that indicates to us. But if, a dentist goes into your mouth, I think here it's probably the case. Like if a dentist goes into your mouth and your gums start bleeding when they floss your teeth, I think they generally take that to indicate not that you have gum disease, but that you don't generally floss your teeth on your own. And if you do, I think your body just sort of adapts to it. I don't know what this means. Your body adapts to it, and then your gums don't bleed every time because you've improved your gum health overall, or you've improved the resistance of your gums to floss. I'm not positive here, but anyway, it did seem that having your teeth brushed before going to bed was better for you. And if you only got your teeth brushed when you first woke up in the morning, it seems like that was a problem, because if you went to bed with a bunch of stuff in your mouth, they were suggesting that, like food residue or whatever, they were suggesting that that could ferment and be productive for infectious bacteria, versus before you go to bed, if you clean out the mouth, you don't necessarily have that additional fuel. I'm putting air quotes around that if you're podcasting, but additional fuel for the bacteria to thrive off of. So it looks like there was no significance to whether you brushed your teeth one time or two times, or two or more times. I don't think that was as important, but the timing did appear to be important in terms of statistical significance. The p-value for that, like when you get up in the morning, it was 0.001, and if it was the risk for just getting it before you go to bed, it wasn't predictive. So, meaning it wasn't a significant predictor, like if that wasn't the reason that you were getting pneumonia statistically. So, yeah, I thought this was really interesting. As I mentioned before, they said the subjects in our study were all bedridden in community dwelling, had severe disability and lack of ADLs, and their daily health care, including oral hygiene, is mostly covered by caregivers. So they did talk about how the incidence of pneumonia here was prevalence. The prevalence of pneumonia in their cohort was 40-some%, right? Like 43%. And they were saying that this is probably higher because it's such an at-risk population. So we know that there are certain factors that can be protective against getting pneumonia, like being ambulatory, being able to get up and out of bed. And overall, none of these patients were able to do that. So they did address like why the rate of pneumonia was so much higher in their particular population, and that could be one of the reasons for it. And the fact that they had long-term NG tubes could itself have been problematic. They did talk about having an NG tube long-term, which I don't think typically happens as much in the United States, but they were suggesting that bacteria could migrate up the NG tube itself, introducing more bacteria from like the esophagus and stomach that could come up that isn't necessarily as much of a problem without a long-term NG tube. So yeah, I thought this was interesting. I really do like seeing what the dental community has to say about aspiration pneumonia. Again, they are talking about dysphagia a little bit here in their in explaining their findings, but they did not specifically look at that as a predictor of whether their patients were going to get pneumonia. They specifically just looked at oral care. So if you're they didn't look at like levels of dysphagia or kinds of dysphagia. Everyone was assumed to have dysphagia because they had these NG tubes. So they weren't pulling out whether dysphagia by itself was an independent risk factor. This is all a cohort of people who already have dysphagia, however they defined it. Yeah. So if you have, I know that this was pretty much off the cuff, and I just discussed these two papers talking about oral care, possibly dysphagia, and pneumonia, whether that was just postoperative pneumonia generally or aspiration pneumonia. I think these papers are interesting, and I think that if you would like to talk to me more about them, that would be really cool. You can find me. Where can you find me? Where are the best places to find me? I'm on Facebook, and my name is Alicia Rivet, Alycia. Last name is Rivet. My email is also my name. It's alicia.rivet@ufl.edu. It's the University of Florida. That's my UF email. So you can reach me there. If you would prefer not to reach me at my UF email, because all of those conversations are archived and could be public record. If you want to ask me something that you feel is more sensitive, you could also email my Gmail account, which is also alicia.rivet, but at gmail.com. But yeah, I think being able to talk about these kinds of papers is really important. I don't think science should be science. I don't think published literature should only be limited to people who have access to it and an affiliation that allows them to get it. And until someone tells me I'm not allowed to share about it or talk about it, I guess I'm going to keep doing it. So if there are any specific topics you would like me to talk about, or specific papers you want me to go over, or additional topics that I brought up here that I'm not an expert in that you would like me to read a little bit more about so that we can both learn more from that, just let me know. I'm definitely open to it, and I read so many papers all the time that it wouldn't be out of the realm of possibility for me to just pick up the paper that you're interested in anyway. So just let me know if you want to talk about that particular topic. Anyway, I'm going to say goodbye for now, and I hope to hear from you if you're interested in any of the topics that we talked about today, if you're interested in my opinion or clarifying what my opinion should be based on what you think or know about the topic. So that's it for now. I hope you enjoyed, and I'll catch up with you later. Bye.